afternoon, everyone, and thank you for joining us at the Be Well Texas Systems and Sustainability Echo. So good to see so many people joining us. Thanks for coming to us on our amended date for this series. Hope you had a wonderful and restful break. My name is Andrea Roche. I'll be facilitating our conversation today. I just have a little bit of housekeeping before we get started. As you just noticed, we are recording all of these sessions and the entire session, and we make it available afterwards on the Be Well Texas YouTube channel. Any information you put in the chat, though, will not be shared on those recordings. Just a few reminders to get us started. Please do stay muted unless you're speaking, and we do encourage everyone to speak. If you joined us on the computer, you can mute and unmute using that microphone icon on the lower left of your Zoom screen. Or if you join on the phone, just press *6 to unmute. We encourage everyone to join by video for the discussion portion of our sessions, just because it's so wonderful to see people's smiling faces. However, that said, regardless of how you're able to show up today, we're glad you're here. There are a lot of us here, so please do keep your comments brief to allow space for others to speak as well. And you can also use the chat feature to share your comments and your questions, although sometimes I might call out for some clarification or for some more language from you if you do that. And as a reminder, in any and all ECHO sessions, remember that no protected health information is allowed either in the chat or in our discussions. I already see people doing this, so thank you to those trendsetters. But to help us with attendance, please enter your name, your affiliation, and your email into that chat feature. Just click on the speech bubble chat icon in the lower bar of your Zoom screen to access that. If you are a Be Well Texas provider, please make sure you identify yourselves in the chat during this session. And if you're joining by phone, just email your phone number and your name to bewelltx@uthscsa.edu so that we can make sure you're on record for attending this session. Echo IT will throw that email into the chat in just a moment. Towards the end of the session, the Be Well Texas team will also send out a link to an evaluation survey for this session. Fill it out for a couple of reasons. It gives us some feedback on what your learning priorities are and how we can shape these sessions moving forward. And it's a great way to get free CME and CNE. And then also, if you enter this survey, you're automatically entered into a drawing to get a $30 Walmart gift card. So please do that just in time for the holidays. Really excited for today's session. We are starting with a didactic from a member of our hub, Matt, on telehealth policies and best practices. And then following that, we're going to have a case presented by Push Up Recovery located in Houston. So we're going to start our session with some introductions of the hub team, followed by those didactics, some announcements from the Be Well team, and the case presentation, and then the best part, open discussion. Thank you again for joining us at today's ECHO. These are spaces for all of us to learn and for all of us to teach each other. So please, I encourage you, share your experiences, share the challenge you've encountered, the strategies you've developed in today's conversation, and let's learn together. So let's start with some introductions. Kathy, I'll start with you.
Good morning, everyone. I'm Kathy Hudgens. I'm an integrated care and substance use treatment program builder and practice transformation specialist. Have been working in this field for quite a while and putting primary care, medical care, substance use, mental health providers together to create sustainable programs.
Thank you. Great to have you with us. Matt.
Hi, folks. Good to be with you today. I'm Matt Roosa. I'm a full-time consultant now. I'm currently working with universities, TTCs, governments, organizations, doing a lot of process improvement, quality improvement work, also implementation science, and training and planning. So I'm happy to be with you all.
Thank you. Leslie.
Hi, everyone. I'm Leslie Manson. I'm a clinical psychologist, and I've been working, researching, consulting, and building integrated care models, including medical, behavioral, and substance use in a professional team since the early 2000s. I'm also a clinical associate professor and director at Arizona State University related to integrated care, and my expertise is related to building fiscally sustainable teams with demonstrated value-based outcomes.
B.
Good afternoon, everyone. My name is B. Brisela Cotois, and I am one of the team members with Be Well Texas, part of UT Health San Antonio. I am one of the program managers, and I've been in the field of substance use treatment services for about 28 years now. Thank you.
Great, thank you, B. Adrian.
Hi, everyone. Adrian Lindsay. I direct our Center for Substance Use Training and Telementoring here at Be Well, Texas.
Thank you. And to some of our support team, Liz.
Hi, everyone. I'm Elizabeth Martinez. I'm the special events planner for our Center of Substance Use and Training under Be Well, Texas. Nice to see y'all.
Welcome, Liz and Krista.
Hi, everyone. I'm Krista Comfort. I'm a community outreach coordinator for the Center for Substance Use and Training. Nice to meet everyone.
Thanks for joining us, Krista. And last but certainly not least, Kizzy, can you introduce yourself, our case presenter for today?
Yes. Hello, everyone. My name is Kizzy Collins. I am the founder and owner of Push Up Recovery. I'm located here in Houston, Texas.
Thanks so much for joining us. Okay, well, we're going to get started with our didactics for the day. Matt, the floor is yours. Go on and screen share, and when you're ready, begin.
All right, give me a second. I'll pull up slides and then we'll go ahead and get started.
And just as a reminder, as Matt is pulling those up, if you've just entered, make sure to use the chat to enter your name, affiliation, and email. Great to see you all today.
So we're going to talk some about telehealth policy, best practices in the environment in which you're in. There's been a lot of, obviously a lot of change and a lot of adjustment to telehealth related services. So we'll spend about 15 minutes or so chatting about telehealth and hopefully shed some light on some of the issues or challenges you may be dealing with related to telehealth and next steps in your process around telehealth. The first thing I want to do is I want to challenge the idea of virtual services, right? Let's think about that for a minute. Virtual. I feel like these pictures represent the real world. I don't think they're virtual. I think these are real world experiences. Everybody, many people are doing what they do through other means of communication. They are not sitting in physical spaces with people in the ways that they used to, and they are doing a wide array of services and supports to help the individuals who they serve. So I think language is important. So when we think about the language, I want us to think about this use of the word virtual and maybe drop that part. These are just services, right? Virtual reality is fake. This is not fake. This is real stuff we're doing, right? These supposed virtual services, they're live, they're in real time. You know, this whole idea of what's in person, I do probably 95% of the work that I do in the same format that we're using right now, some sort of a video conference environment. They feel very personal and very real. And I think those of you who have shifted your services can attest to that reality. There's this difference between this environment and the physical space, but I think we need to ask that question. What is the value add of being in the shared physical space? And that's a bit of a contrary notion to what some of you may support. I'm not suggesting that that one is better than the other. They're different and they have different advantages. And I'll talk a little bit about some of those. I think we have a history of viewing in the room with people as necessarily the better of the two. I think we need to keep questioning that assumption. We have different locations. We're doing services in different environments. And so I'm encouraging you all to kind of think about language and how you use it and how you frame this idea of services through various telehealth platforms. So some simple objectives for us for today. I want to think a little bit about the current state of tele-based care, review some of the policies from a broader systems perspective related to tele-based care, and review the current decision-making process around the future for yourselves and for the broader systems in terms of federal level supports that are currently in place that encourage telehealth services. So if we think about the path to where we are right now, we started off with pretty much predominant face-to-face care. There were some early adopters of various platforms and telehealth services, but for the most part, we were doing physical in the same room care with people. And then, of course, COVID arrived. And that caused us to make some major shifts and a pretty tremendous crisis related to access to care. And folks needed to make some really major adjustments, a lot of innovation a lot of new policies and procedures and activities, infrastructure, technology, training that all of you, of course, have experienced across the last couple of years, which established a new normal that you currently are experiencing. And then starting to think about, so now what? Where are we going from here? I've heard some people saying, I want to get back. We've been working hard to get back in the rooms with people. And other folks saying, it's really great to have all of the options that we have now, and a wide array of different reactions and different thoughts about the future and where we are now. So let's talk a little bit about the innovation space in terms of current policies and procedures. So OBOT minus the O, right? So office-based opioid treatment minus the O. We've had some pretty significant changes, federal policy changes, right? So people who are receiving methadone treatment are being able to have 28 days of take home. I don't know if you had conversations at the very beginning, if you were related to opioid services in any way, either as a provider or some other affiliation. There was a lot of angst about this. You know, there was a lot of concern about this, and it seems to have worked out quite nicely. Our cautions, our worries, of course, were well-founded. We wanted to make sure everyone was safe. And I'll show some stats toward the end of the presentation. It worked out well. Doing inductions with people with buprenorphine without needing to be in person, doing that through a teleplatform, which has become much the norm in a lot of different environments. Medicaid and Medicare being billed for telehealth services, so payers paying for telehealth, and waiver, the capacity to prescribe for folks prescribing buprenorphine for less than 30 folks without the 8-hour X-waiver training. So all these things increasing the capacity of systems to do telehealth services. DEA response as well, pretty substantial, shifting from an in-person orientation toward allowing telehealth environments to be approved by the DEA and supported. We see a lot of resources now from DEA and others that are allowing us to continue to do telemed, not just the initial telemed opportunity. That was some of the reaction on the front end, which was, okay, on the front end in an emergency, you can do telehealth, but you've got to back that up with something else. And now we're seeing a supportive ongoing and continued telehealth resources. E-prescribing as well, right? So we can do prescriptions. We don't have to be eyes on the person in the same physical space in order to prescribe medications for those who need them. We see at the federal level through CMS, payment at the same rate for telehealth or services. So there's this parity that's pretty substantial in terms of driving the service delivery. We know that when services are being reimbursed with parity, then that drives volume of those services. And we see that that's the case now with telehealth services through CMS. The requirement for the relationship prior to telehealth that used to be in existence through CMS, so Health and Human Services, CMS under that umbrella of Health and Human Services, now saying, no, you don't have to have that. They can be a new person, a new client for you. So not only existing clients can you serve through tele, but also new people as well. And you can use all of the common platforms for these teleservices, right? These platforms like Zoom and Skype, et cetera, that can be effectively used. There was a lot of concern on the front end and issues related to privacy and security that were worked out, and folks were able to recognize that these platforms have adequate security and safety and can offer a very great opportunity to deliver care in a safe and private fashion. Really nice resource if you want to check out the Foundation for Opioid Response Efforts, or FOR. The website is there, and we will certainly make sure the link, I should say, is there, and we'll offer up resources like this for you to take advantage of. So there's some nice overview of policy issues and changes that I think are really helpful, particularly as you think about your own planning as it relates to telehealth services and resources. So then what becomes the new normal based upon all of these bigger systems, rules and requirements and regulations that have been adjusted to accommodate telehealth for all of you? So what's this new normal that people are experiencing? So we see telehealth during the pandemic. It was associated with improved retention and care. This is what the data is telling us. We have better retention if we can offer telehealth services. Reduce odds of medically treated overdose, actual reduction in the odds of medically treated overdoses. We didn't see an increase in methadone-related deaths. As I said, even with those 28-day take-homes, which caused a lot of angst, as I said, for many people, the data says that this did not result in an increased death rate. So that's a really important finding. So there's a lot of support for permanent adoption of these changes to make them the new normal. And to have these strategies kind of driving the future of care and creating these new opportunities and this new array of choices for you in terms of how you deliver care and how you can potentially increase retention because you create access points that are different and that are more manageable for a number of your clients. So here's a simple example of how policy tends to drive policy gets driven by culture. These are two states, just a quick snapshot. And as I say this, I want to make sure that this is in no way intended to disparage one of the two states. You'll see the difference, but just to point out how culture, practice culture impacts policy, which impacts how people adopt things like telehealth. So in the state of West Virginia, the state requires individual and group counseling for ongoing medication for opioid use disorder access. And there's really there's a challenge in some of the rural environments for telehealth services. And providers tend to agree with this orientation that they want to require these individual and group counseling for ongoing medication access. This creates a pretty substantial barrier to care. Now we'll contrast that with New York State as our example with a different orientation, which is a clear prohibition on that same requirement. So in West Virginia, that is a state regulation. In New York, there's a prohibition on that practice of requiring individual or group counseling for ongoing access to medications. No, New York State's significantly more urban, significantly larger volume of providers per capita. And the providers in that state tend to agree with that orientation, which is that we don't want to create any limitations. So if you think about these two environments and then think about telehealth services, we are going to see some challenges to access of telehealth in West Virginia that we won't see in New York. So those beliefs and those practice patterns are going to be driving how folks envision telehealth and how they'll use telehealth. So think about your broader environment. How is your broader environment regulatorily supporting telehealth? How might it be getting in the way of telehealth services? So now what? Where do we go from here? What are providers saying as they think about the future and as it relates to teleservices and supports? So what are they going to do now? Here are the kinds of things that I've been hearing and that probably some of you have been hearing as well. This has created an access to care that's improved for many, not everyone, as we well know. There are some folks for whom telehealth has not worked out as an increase in access for them because of a range of different challenges, technological challenges, privacy, environmental issues within their home settings, et cetera. But by and large, big picture, it has improved access pretty substantially. It's hard for some people. We've learned that. There are some people for whom this has been challenging. Both staff and clients are recipients of services. So we have to honor and recognize and figure out what we need to do to help those folks to accommodate or to make accommodations to ensure that folks get access and to understand what those are and then act accordingly. Some patients have struggled with telesupports, others have done really well. So again, differentiating between individuals and taking a very person-centered orientation to teleservices. This is not a one-size-fits-all use of technology. So we need to think about how individuals respond to those opportunities. Many providers saying these are new options we never had before. This is good. We can now be more intentional and thoughtful about how we do what we do, and we're not going back. people are saying we're not going to go back to what we used to do. This is a great opportunity for us. So how are you going to hold on to your what kind of orientation does your environment have? And how are you going to think about your organization's values and using telehealth as you look into your own future? And how do you create your new normal and live your new normal as you think about that? Obviously, you need policies and procedures so that you have a map. And remember that the road is moving. The road keeps changing. We get a new turn at each corner, and we have to then reassess and reconsider as we continue to work to expand our use of telehealth in ways that hopefully can provide more recovery opportunities for everybody you serve. So that's the end of that didactic. I thank you for listening.
Thanks so much, Matt. And if you're interested in this topic on telehealth, just stick around for our announcements. We've got some other exciting programming coming up. I want to open the floor to questions, but actually Kelsey dropped a couple in the chat earlier, Matt, I wanted to draw your attention to. Kelsey, I'll just read these, but if you want to clarify anything, please just unmute and share. But the question, isn't tele backup in jeopardy now? They're thinking teleservices for controlled substances may not be extended in the coming year. And this is a question, Matt, to you, but actually to anybody on this session who has some information on this. We heard about these policies changing or reverting back. And then Kelsey goes on to clarify, so something that would require people to come back into the office for insurance purposes.
Yeah, I would open that to everybody and see what we have for cutting edge awareness. What's the latest that anyone has heard in the last several days about any changes related to this question? Does anyone have something that they'd like to share? What do you know? And I do think sometimes we have federal guidance, we have state regulations and guidance, we may have professional or trade association guidance. So some of these things kind of get conflated and crossed with each other. So does anyone have any clear guidance that they're aware of that's in sort of in opposition to the trend that I was describing, which is that more open environment? Is someone seeing something very concrete in the other direction?
I think similarly to the comments in the chat and folks probably who are on, I do understand this kind of normality that we are all seeing, but at the same time, right, federally and statewide, there's been a lot of pushes to sustain the changes temporarily. So every 6 months to a year since the pandemic, we've seen these pushes to provide extensions, and there so forth hasn't been a permanency related to the language. I believe we're all hoping for that. There's a lot of discussions related to that, but we really won't know until we walk through the next legislative process and see how that all goes. I don't know if other people have different ideas, but that's kind of been my feeling related to that. There's been some great extensions, which has been wonderful, which kind of breeds towards sustainability. But there's always discussion. So,
and of course, the political process, the path of least resistance with regard to extensions as opposed to permanent. We all would like to see permanent on many of these things, but political processes being what they are, we tend to see multiple extensions on many things as part of that change sequence.
I guess is a silver lining of multiple extensions. It gives more time for more data, for more support, for solidifying something. Yeah. Andrea Yatsko asks, I think, a similar question. And I think, Andrea, if there's more we can answer, please just unmute and let us know. But just are the federal guidelines still technically temporary? I think that's kind of what we've been kind of chewing on a little bit.
Yeah.
Well, given that, we'll get to our announcements in just a moment, but given that, is there, with the understanding that the road may twist, that these extensions may go away and be replaced with nothing or be replaced with some version of what we've seen to this point, is there, from a system standpoint, is there a way to kind of plan for flexibility? What are some of the big considerations as an organization you might be thinking about right now that whichever fork in the road we take, we aren't just sort of completely lost with the next legislative session, with the next emergency period, whatever that is. It's a very open question, but basically, how do we stay flexible as organizations?
Yeah, I guess my clearest guidance would be, don't do what I'm just about to say. Hey, everybody, telehealth's going away. Let's toss these cameras and get back to our usual work. Let's not do that, right? Well, let's maintain our capacity to use all these different options. Let's maintain the infrastructures that we built. Now we can be intentional across a wider array of service provision, and let's watch the guidance as we move forward. And my position would be to continue to advocate for choice. This is part of a range of choice. If well and thoughtfully implemented, how could this be problematic to have a broader array of choice for creating access for individuals who need care? And we've seen from the data so far that this works and that it helps many people. And as long as we're thoughtful and have that person-centered orientation, let's maintain our options for care.
I agree, Matt. And I think in addition to advocating for sustained change, I would make it very clear and be transparent with your patient base that this could go away, that it could be temporary. Whatever they're participating in is really helpful, but it may not be there. So this would be sort of an ongoing consent process, so they know what their services and their limitations are, but that you're working on it, because it would, I've seen a lot of systems who, when something like that shifts, it shuts down, and then there's a degree of distrust and confusion. So just making sure that keeping them updated on that progress is something I would suggest.
Great feedback. Vanjie, you had a comment here. It's not a binary system. I wondered if you wanted to share a little more. Well, that's all right. I think I can appreciate the comment that there's no yes or no choice here. There's no right or wrong. It's really a spectrum of services and what's best for your providers, for your staff, and for your patients. And yeah, Kelsey, thanks for sharing the feedback. It's exactly as Matt presented. You really need to take into consideration what is working for your patients and prioritize that. While Carly is pulling up our Be Well announcements for the day, I wanted to mention something I neglected to at the very beginning. So everybody knows these sessions are enabled for closed captioning. If you would like to enable that on your own desktop so you can view closed captioning, just navigate to the bottom of your Zoom window. It's usually over under the More menu, the 3 dots More menu, and there's an option for captions, and you can turn those on for yourself. My apologies for not bringing that up sooner, but I hope that's a helpful way for folks to access this session. Thank you, Carly, for sharing our announcement slide. So a little bit more about Be Well Texas. This is a welcoming environment with caring professionals ready to help people start or continue their journey toward recovery. Be Well Texas is committed towards equitable access for compassionate, evidence-based treatment and care for substance use disorder throughout Texas. Next slide. The Be Well Texas Clinic provides high-quality treatment for addiction and mental well-being, offering insurance, self-pay, low-cost, and no-pay options. So you can visit them online at bewelltexasclinic.org to learn more. Next slide. Also, just a call out, if you need technical assistance beyond what's offered in these ECHO sessions, we encourage you to connect with the Be Well Technical Assistance team. Just complete a quick online request form, and that team will be happy to assist you and offer you more individualized support. Next slide. And this is an important reminder as we're getting towards December. We will not have a December session for this series due to the holiday. Our next Systems and Sustainability ECHO will take place on January 26th. So we wish you all a happy holidays. And after this, don't leave now, but we'll see you in 2023 after this session. Next slide, Carly. And I mentioned this before, if you are interested in this evolving landscape of telehealth for substance use disorders, check out this panel discussion with leading experts featuring our own hub member, Leslie, coming up a little bit later in the month. You can go to txsus.org and register. And Liz, I wonder if you might be able to drop that link in the chat a little bit later for folks so they can easily get there. Next slide. Oh, I don't think there is another slide. Thank you, Carly, for covering my gaffe. Well, so let's get to our case presentation for the day. Kizzy, Carly will pull up the form that you presented. And as she's doing that, I just want to give a reminder to everybody here, there is so much expertise in this room already. People who face similar challenges or have ideas of resources that might help our presenter for the day. So I really encourage you all to speak up, whether that's in the chat or if you feel comfortable unmuting and sharing in the conversation. And let's learn together and see if we can share some resources that are helpful today. All right, Kizzy, take it away. Tell us a little bit more about your situation and how specifically this group can help you.
Okay, great. Thank you. So as stated, my name is Kizzy Collins, and my organization, I'm the founder of Push Up Recovery. We provide recovery support and services to the community at large. Currently, we have 4 employees. We have 2 full-time employees and 2 part-time employees. The healthcare professionals that we have are professional peers, peer support supervisors, and peer support specialists. The headquarters is located at the 26 South Loop West in Houston, Texas. So with Push Up Recovery, we promote health and wellness for individuals and families in the community by providing recovery support and services. We do a lot of advocating for people in recovery in the community at large, like established community relationships and partnerships for the enhancements of our service delivery. For example, a Harris County Health Department outreach community team, Strategic Solutions, who train our recovery support specialists, as well as Anchoring in Hopes that helps with our recovery and wellness RAP action plan. We conduct recovery support groups. We locate, share, and connect community. We locate and share and connect with our community suitable resources. Okay, suitable resources, which means resources that are tailored to the individual, person-centered, participant-centered resources according to their individual recovery plans. Peer workforce development, like stated earlier, we have peer support workers, and we also have 4 that's about to train starting next month. We supervise peer workers. We educate the public by attending and participating in community events and conducting presentations per request. So for example, tonight I will be presenting at the University of Houston regarding recovery support and services, as well as next month, we'll be presenting to the Harris County, sorry, I'm nervous, the Harris County Department of Health, the entire team. And so we also provide supportive, safe, and suitable recovery housing. We are a Be Well provider. And we provide additional services as needed and requested, such as community outreach. Some people, we go into their homes and connect them to services that they're needed, that are needed. So what are the desired outcomes? Actually, what I'm doing is like paying it forward. Most of these services are services that I have utilized at some point and maybe even continue to utilize in my life today. So we're helping families, we're helping individuals, families, and communities that are often perishing because of lack of knowledge, understanding, support, and resources. And oftentimes, maybe like with referrals, not only from a personal and a professional experience, sometimes referrals are a person is referred out. However, just the different loopholes or maybe the different red tapes that are present make it hard. So what we try to do, we aim to directly connect them to one of the key people, personnel that will help them receive the service versus just referring them out. What had made the difference for myself is I had a safe place to go. during my primary years. My family background is a history of domestic violence, and I'm saying like on a daily basis. We just never knew what we was going to encounter once we came home. Both of my parents were active in in substance use. My father actually died as a result of his addiction to substance use, and my mother continued to this day. We endured physical abuse, emotional abuse, and sexual abuse. Nevertheless, at times I did have a safe place to go, and even when I found myself homeless as a teen, after my father was killed by one of our siblings, I had a safe place to go. And I know that safe spaces and safe people and safe places are very important. Things could have turned out a whole lot different for my daughters and myself had it not been for having those safe people, safe spaces and places. I testify to that recovery is not only possible, but recovery happens. I'm evidence. Considering the facts and what I've endured, according to the status quo, I shouldn't be where I'm at right here today. And I just want to briefly add, I do have 3 of my daughters who have successfully graduated from school and 2 that have successfully graduated from college as well. Push-up recovery, briefly described our funding structures. I'm currently working on the Push-up Recovery Outreach Ministry, which currently we are a for-profit, and our primary funding streams have been self-pay, grants, and it started out with my personal savings. Like I had storage of things I had been accumulating over years. And so, however, we are currently in the process of creating, like I stated, the nonprofit organization for the recovery outreach part, and also developing or working towards individual apartment units for mothers who age out the foster care system, like the aftercare part. And so we're working towards having those apartments developed, as well as a daycare center on the same premises. And so I recently just found out prior to finishing this that we were awarded, Push-Up Recovery was awarded a grant through the city of Houston for long-term housing. And also was recently awarded a contract with the Harris County Juvenile Probation Department, servicing the entire family. So not just the youth that is on probation. So right now, what type of health and behavior center for systems in our organization? Once again, recovery support services, peer-owned, peer-led, peer-run. So what we do, we're hiring peers. We're developing a peer workforce, credible messengers, people with lived experience. And so that's the nature of the services we're providing. So what category best describes service implementation? And sustainment challenge. The financial models, workforce development. So we kind of didn't got that. The workforce development is better now because we've partnered with Strategic Solutions, who will be doing the training for the peers. And also the sub-services is often a conflict with the lifestyle of individuals in recovery. So for an example, what that means is that some services are outpatient or offered during times when individuals work. And so it becomes like, where do I get the services that I need? How do I complete these things that I need to complete and work at the same time? And there have been several times when individuals have literally lost their jobs, either that or go to jail. So that has been one of the issues that we have encountered. And once again, the financial models, being a small business and initially starting off as a one-person business owner, I had experienced a lot of challenges with just trying to balance and understand the whole operational part. However, I have sought out a lot of guidance and counsel. Can you pull the slide down some? And I have individuals that's working with me. What process stages below best reflects the location of your challenge? Unsure across multiple process stages. What I've learned in the recovery field is that like substance use is like just a portion of the issue. You know, it's so many other things that come along with that hinders people from moving forward, whether it be the services that are supposed to be available that are not really available unless you know how to navigate that system. Trauma, unresolved issues, the need is so great. It's hard to just focus on one area when you're trying to help the person improve their entire quality of life. And so there has been a high turnover rate in staff who provide services just because of the caseload, the burnout, the not enough self-care, or just the need being so great and needing to fill in the gap for the services that needs to be provided when other staff members leave. Another thing is participants either lacking or losing hope during the process of change. Participants' core values and beliefs are sometimes a hindrance, you know, maybe not knowing how to ask for help, maybe saying this is how we've always done it. So it's not just a form of rehabilitation, it's sometimes habilitation, to learn a complete new way of living because I never knew the correct way to begin with, you know. So we're dealing with belief systems here and just traumatic events, you know, those individual wounds, you know. So how do one become better when it's internal bleeding on the inside, you know, that's leaking out? I mean, so it's kind of, it's a lot when it comes to the recovery, and just having the courage to even face that. It's very difficult at times for individuals. What obstacles and factors are contributing to this challenge? Policies and procedures. I'm just going to say policies and procedures and keep it simple, because sometimes the policies and procedures are not favorable to the recipients. The leadership, you know, sometimes people that are in position of power to help may for whatever reason choose not to help, may for whatever reason choose not to go above and beyond to assist the individual that's in need. Sometimes the staff and the funding, people not having enough monies available to have staff present to help render the services, and a lack of collaboration. You know, I have, prior to being an entrepreneur, I have worked in several places to where it was division among the staff, you know, which defeats the entire purpose of what we're working towards, which is helping our community, right? And people who's coming in for services. And so what are the top three key strengths that our team bring to this effort? Like stated, lived experience and long-term recovery. I've been in recovery for over 17 years. Trained and certified professional peers, which means that each person is required to be trained and certified, and commitment with passion and courage, you know, and so with compassion, you know, just being able to empathize with another person's situation and not having an opinion about it, but just knowing that the goal is to assist that person in the way that person would like to be assisted, and courage. Not courage from fear, but courage to endure and experience some of that grief and pain and walk with people through the process in spite of, you know, just deciding that it's too much and it's overwhelming. And sometimes it is that, but that's where the self-care comes in at. What past successful implementation strategies have we used that could be applied to this challenge? Once again, person-centered, relationship focus, connection, advocacy. We have to do a lot of advocacy, advocate and be behalf of the individuals that we serve, because oftentimes some have not learned how to use their voice for different reasons. Discovering possibilities, knowing that there are options available. Learning how to experience defeat without being defeated. You know, I got told no 3 times before I got a yes over a year period of time. And they say, you back again? Yes, I'm back again. And so, because I went back and did what they required me to do. I didn't just come back. You give me something else to do, then I'll show back up with that. And so that's something that our participants are, we like to assist them and show them how to meet the requirements and not just accept the defeats. And once again, supportive and suitable services. There are many times to where we've used curriculum to where it was like over individual heads, you know, to put it to where it's simplified and that they can understand it, or have staff that's in a position to be able to assist persons in understanding and then respecting individual worldview, you know, the totality of their story, and not having an opinion about it. So, and what I mean by not having an opinion about it, not being judgmental about it. What is the best indicator? That you have successfully resolved the current challenge. Progress. Participants making progress or completion of their individual goal or goals. Participants initiating and sustaining recovery, as well as harm reduction. So the questions that I will have for the community right now is, what strategies are you using? What is working for your organization? Thank you.
Kizzy, thank you. I think in a little bit of time, we're bringing you back for a didactic. I want to make sure, first of all, that you can see the chat, because you have got some cheerleaders in the chat. A lot of thanks, a lot of applause, and just congratulations on how you have grown, how you've grown this this center, and just the generosity and compassion with which you support recovery services. I want to jump right into the conversation and want to thank those of you who are popping questions over into the chat. I'm going to start with some of those. First, I'll just reiterate what Kathy mentioned to us all. Let's think about those of you especially who have some experience transitioning into the nonprofit world, or who are working from those early stages of grassroots and building up. Any resources, any strategies you want to share, be thinking about those and be ready to share them. Richard brings up a question, Kizzy, if you might answer, just what processes do you have in place to find or to recognize additional funding streams or resources? Congratulations, by the way, on the two opportunities you described. But do you have a mechanism in place for finding new ones? And also, just part of that, is there somebody on your team who is a grant writer who could maybe assist in applying for those funding opportunities? Okay, so that was a lot of questions. That was one question. So let me see if I can remember it. So I know no one on the team is a grant writer. I am a member, the organization is a member of Urban Awareness, so we're notified constantly of grant and in-kind opportunities, whether it's for-profit or non-profit. I'm also with a part of the Houston Community and Housing Development Initiative, which is like a Section 3 business and a Section 3 worker as well. And so I get a lot of information regarding grants and opportunities with grants and opportunities that are available. But honestly speaking, like right now, I'm still working on building a team. I do have Dr. K and my consultant with the University of Houston that are passing along a lot of information, but the time to sit down and actually do the grants, to complete the grants. So no, I don't have help with that. I think, did I miss a question? No, I don't think so. And Richard, I want to pop it back to you, because I think it's sort of what I pick up from your question is that is an important kind of role. As you're thinking about your staffing, is that kind of administrative or grant support something you would say is really important to factor in?
Yeah, I would think so. You know, when I look at some of the smaller organizations, the groups that are so passionate, Kizzy, thank you so much for just your commitment, your passion for doing this work, and it's just you're doing a great job. I just know that those are barriers and challenges that a lot of people starting out have. It's like, you know, being able to recognize where that funding is, and then being able to apply for it, and having those processes in place to kind of, you know, write for it effectively. And, you know, all those grants are competitive in nature, so sometimes that creates some of the challenges there. So it's good to see you're getting help from University of Houston and others in the Urban League. So, great.
Yes, thank you.
Great. We've got some other questions bubbling up in the chat, but there's just some quick ones I want to ask. Kizzy, can you tell us what PUSH stands for? And if you all have like a social media or online presence?
So PUSH stands for the purpose, unity, support, and hope. And we're working on the online presence. I'm in the process of, I have created the profile, but I'm working on getting someone to help me with that social media piece, one of the new peers that will be trained next month. And we do have a website that, we have a website. And so working on updating that to our current status, because a lot has changed since we initially developed that website. Yeah.
Well, that's terrific. Okay. And thanks for explaining the acronym to us. We have a question from Leslie here. I think it's a couple of questions. So you're on a pathway to become a nonprofit. Is anybody helping you along that pathway? Anybody helping you become a nonprofit, giving guidance or partnership?
So we're establishing a nonprofit. We will still have the Push Up Recovery, the LLC. The nonprofit is already formulated and has the nonprofit status. We're working on the bylaws and all that stuff. So getting all the getting all the required documents in place. And what the nonprofit was initially formulated for was, I was donating a lot of wellness baskets and wellness bottles to the community that would that house individuals for substance use. And so originally it wasn't with the intent for grants and everything, but now we'll expand more since the business is expanding. Push Up Recovery. So we'll have two, but they'll be separate.
Got it. Thanks for the clarification. Leslie, I want to come back to you for the second part of your question, if you might sort of expand on that a little bit. About opportunities for maybe partnering with other community agencies to contract the services. Leslie, did you want to clarify that a little bit more? I might have.
Sure. Yeah, I love everything that's being stated here, and obviously an extremely valuable benefit to the community. And I'd love to see it be able to build even more, right? So one of my thoughts was whether or not you're able to reach out to some of the local FQHCs, ACOs, also perhaps specific substance use organizations or other nonprofits, and consider contracting yourself and your employees for them to provide peer supportive services, groups, other type of care management, et cetera. So they could actually bill for those services, but then provide you a contracted rate, just giving you other ways to be able to expand those services, and maybe even through telehealth, like that was presented earlier.
Yes. Absolutely. And I wrote that down about looking into the telehealth services. And so we do have Ms. Moore anchoring in hopes that it's in the process of recruiting contractors in reference to the contract through the Harris County Juvenile Probation Department. And we do have a one substance use facility that we are collaborating with, which is Revive. So that we're working with her and maybe going to add a few more. So that may be state funded, because she's not state funded. That way, individuals who are not able to pay for it will have some more options. So just honestly speaking, it's like all of it just start happening all at one time, and it's like, I'm just trying to digest it and connect with the right people that can help and help us navigate as we expand it's almost like we went to like just me spending my savings on this. So many opportunities to where it's kind of overwhelming a little bit, just being honest. But we're working through it one step at a time. Yeah.
That's a great point. And I want folks to kind of hear that and see if anybody who, well, Kizzy, it almost sounds like you've heard the old line, like you're building the rocket ship after it's launched kind of thing. The good news is you're building a rocket ship, but the bad news is you've launched. I wonder if anybody in the audience has been in that place where it's really exciting. A lot of growth is happening, a lot of partnerships, a lot of interests, a lot of opportunities. Any guidance you might give, Kizzy, what you kind of learned in navigating through all of that, how to say yes to the right opportunities, how to keep doing this work when there's only so many hours in a day?
I would offer one quick suggestion, Kizzy, which is that I just appreciate your spirit and how you do your work and the push that you're putting behind all of this work. You know, if we start stuff when we're ready, then we never start stuff, right? You start when you can start, which is what you did, and then you got to keep doing your thing. So just because things aren't what you want them to be, that doesn't mean that you weren't at the spot you should have been to start it. You know, none of us are ready to start anything we ever start. So I just appreciate your work.
Thank you.
Great comment, Matt. And I know we're getting up on the hour, but we did have a question from Megan in the chat. Kizzy, the question is, does PUSH have a medical provider seeing patients, like providing medication, excuse me, for opioid use disorder? And then a follow-up to that, is the housing a sober living setup or something different than that?
The housing is identified as a recovery community, so it is a sober living setting. Ideally, sometimes things happen, but we still work with individuals and get additional help that's needed. That's why we are working with substance use treatment facilities. Yeah, because.
Great. And Megan's asking in the chat if we can get your email, Kizzy, if you're able to drop that in the chat. A lot of folks have been talking about how helpful this kind of program will be in the Houston area and wanting to connect. Any other thoughts for Kizzy before we go to our concluding remarks for the session? All right, Kizzy, I want to thank you for a really engaging and lively conversation here. I'm going to turn now to B. If you could summarize some of the key points from our conversation today.
Yes, that's Kizzy, kind of an hard act to follow after that presentation. Thank you. Do want to circle back to what Matt covered, which is, again, the importance of recognizing and being aware of the times, and for those of us that are in the field, being cognizant that we have to be flexible and that there are now more options available that improve access for everyone. And we should just focus on more options for services instead of focusing on the terms such as virtual, telehealth. But just the new norm is more options available for services. And of course, the importance of language and making sure that we are incorporating policies that fit that service delivery. And also the importance of the federal guidelines, which are still in temporary status. We are hoping that that will change. We continue to hear it'll happen in the next 3 months, and that keeps getting pushed to 6 months. So we continue on these extensions. But as Matt mentioned, some of the outcomes have been very positive in regards to retention. No increase in methadone deaths were some of the things he touched on. So it really is looking very positive for these temporary guidelines to hopefully expand and become permanent. And of course, Kizzy, your presentation really clearly shows the importance of having that passion and that commitment. And then I think that's really what drives organizations to grow and develop. And the focus now needs to be on maybe becoming more affiliated with organizations that can help you take those next steps on expanding your service line, on helping you write for some of these possible funding opportunities, and working with your community. It sounds like you're working with the university, which is a great resource, and you can find a wealth of resource there to hopefully help you expand into taking those next steps, along with, as I mentioned, getting affiliated with some large organizations such as the National Council on Behavioral Health is a great national organization that can do a lot of one-to-one consultation with you. And I'll drop that in the chat. And I believe Dr. Lindsay was going to drop an organization name in the chat. If not, I will drop it in shortly.
Great, I've got that. And I think Adrian might have needed to step off. And so it was, what was it? Social Venture Partners. I'll throw that link in the chat here too, to help nonprofits getting started. Well, I want to thank our didactic presenter, Matt, for a great conversation. A reminder, if you're interested in the world of telehealth and all things related to substance use disorder, please do check out that live webinar on the 9th. Through txsus.org. And thank you to Kizzy so much for that wonderful and case presentation, and for inviting us into your journey. And congratulations on all you've done so far. And thank you everybody for such a lively conversation in the chat and in this room. A reminder, we aren't going to have a session in December, but we'll see you back in January. Have a wonderful rest of your week. Thank you.